Okay, after multiple attempts at trying to do this a different way, I am just actually doing what they call voiceover on PowerPoint. So this will be probably a lot easier for you guys to go back and look at and to actually listen to. So remember that this is chapters 21, 22, and 23. So we're going to go ahead and get started. We know that the abdomen is actually a large oval cavity, right? We know that it extends from the diaphragm, it goes all the way down to the brim of the pelvis. It's actually bordered in the back by the vertebral column and at the sides and front by the lower rib cage and abdominal muscles as well. There are 4 layers of large flat muscles from the ventral abdominal wall, and those muscles are actually joined at the midline by a tendinous seam that is actually called the linea alba. All the internal organs are called viscera, and when you are palpating the abdomen, when you are actually palpating different organs, some of them you will and will not be able to feel. The liver is one that you may be able to feel, but it's important for you to know that in most people you probably won't be able to palpate it. So this is not abnormal. If you can palpate the liver though, this would be a time when you would want to at least ask a few more questions. Remember that also when we are listening or auscultating for bowel sounds, that one of the reasons that we want to make sure that we hear bowel sounds in all 4 quadrants are because we have intestines that are actually located in all 4 of those quadrants. Here are just the internal structures of the abdomen. I really just wanted to show you this as far as the anatomy and how it all kind of goes together. And you know that the liver takes up a large percentage of the abdominal cavity, with the spleen right behind it. Okay. In the right upper quadrant, of course, is where we're going to find the liver, the gallbladder, the head of the pancreas, the right kidney, and the adrenal gland. We're also going to find what we call the hepatic flexure of the colon, which is just that part of the colon that is near the liver itself. And then, of course, we have part of the ascending and the transverse colon. In the left upper quadrant, of course, we have the stomach, we have the spleen, we have the left lobe of the liver, we have the body of the pancreas, and we have the kidney and the adrenal gland. When it comes to infants and children and us assessing especially the abdomen, there are a few things that we really kind of want to keep in mind. In the newborn, of course, that the umbilical cord is what you are going to see prominently on that abdomen. It actually contains 2 arteries and 1 vein. The liver is going to take up a much larger space in the abdomen at birth than it is later in life. And in a healthy neonate, the lower edge may actually be palpated anywhere from 0.5 to 2.5 centimeters below the right costal margin. The bladder is also located a little bit different in an infant and in a child. It is going to be higher in the abdomen than it is in the adult. It's really going to lie between the symphysis and the umbilicus, so it's up a little bit higher than right there at that pubis symphysis. During early childhood, the abdominal wall is less muscular, so organs are going to actually be easier to palpate in this situation. In pregnant women, remember that pregnant women a lot of times are going to experience nausea and vomiting, or what we refer to oftentimes as morning sickness. This is generally a first sign to the woman that she happens to be pregnant. It usually begins anywhere between the first and second time that she misses her cycle. The cause is really unknown, but most people believe that, and physicians as well believe that it's because of the hormone changes and the high levels of hormones, HCG being the primary one. Most physicians will tell pregnant women that the higher their HCG levels are, the more healthy that their pregnancy happens to be. Another symptom that pregnant women experience on a regular basis is acid indigestion, or heartburn, or pyrosis is the technical term for it, which is caused by esophageal reflux because of the baby actually pushing up and displacing a lot of those abdominal organs. Remember that their gastrointestinal motility is also going to decrease at this time. This is because there's not quite as much room for those organs. And this is actually going to prolong the gastric emptying time, which is what is going to cause that actual acid indigestion, because it's not emptying quickly. The decreased motility actually causes more water to be reabsorbed from the colon, and unfortunately this is going to cause them to have increased episodes of constipation. There are also two other conditions that we notice on the abdomen, oftentimes in a pregnant woman, called the linea nigra and what we call striae. The linea nigra, if you look at the picture of the abdominal belly, it just looks like a dark line that extends all the way from the top of the fundus down to the pubis symphysis. This does go away after the woman has her baby, but this is very prominent in pregnant women. And striae is actually just a fancy term for stretch marks. In the rapidly expanding abdomen over such a short period of time, unfortunately, you're going to see that a lot of times that tissue and that skin, the abdominal skin, just is not able to keep up with how fast it's stretching, and it will cause these striations. A lot of physicians will also tell you that striae are most likely, at least in some form, genetic. So ladies, if your mother had lots of striae or stretch marks when she was pregnant with you, then the likelihood is that you will also have them. In an aging adult, remember that with an aging adult that the abdomen itself is going to look different. It's going to have more subcutaneous fat. It's going to have more adipose tissue because remember that it becomes redistributed, and actually that adipose tissue starts to collect more in the abdomen, actually falling away from the face and the extremities. And remember that the abdominal musculature relaxes. Why? Because of course they're not as active. So those muscles are going to lose a lot of their tone and they're going to become much more relaxed. Males especially are going to have more fat deposits in their abdominal area, generally resulting in what we refer to as a spare tire. And unfortunately, the more sedentary that their life becomes, the more likely that they are going to be to see some of these spare tires, as we like to say. Changes of aging are actually going to occur in the gastrointestinal system as well, but they don't necessarily affect function when there isn't any kind of disease that goes along with it. Remember that as everything that goes along with aging, that most things are going to be decreasing. Salivation is going to decrease, which is going to result in a dry mouth. And most older people will tell you that this also affects their sense of taste, that they don't taste things like they used to anymore. Esophageal emptying is going to be delayed, so food that is traveling through the esophagus is not going to empty as quickly into the stomach for digestion. If an aging person is fed in the supine position, so if they're laying down, this is going to significantly increase their risk of aspirating, so actually sucking in some of those nutrients into their lungs. Gastric acid secretion decreases with aging, and it may actually cause what we call pernicious anemia, and that is because it interferes with that vitamin B12 absorption. So a lot of older adults actually suffer from iron deficiency anemia, and they are unable to absorb calcium as well because of this. The incidence of gallstones also increase with age in an older adult. In about 10% to 20% of middle-aged and older adults, we're going to see these gallstones occur, and it is actually much more common in females. The liver size is actually going to decrease with age, particularly after the individual reaches about 80 years. And even though that liver size is going to decrease, generally speaking, the liver function actually remains normal for these individuals. Remember that because of the decreased salivation, because of everything being delayed, that a lot of times drug metabolism, especially by the liver, the liver is impaired, in part because by age 60 and up to about age 80, blood flow through the liver is decreased, which is why, again, that liver actually becomes smaller. Therefore, liver metabolism that's responsible for the enzymatic oxidation and the breakdown of drugs is substantially decreased with age. Aging persons frequently report constipation. This is something that you will hear over and over again from elderly patients that you take care of. Primarily, this is because of that gastric motility slowing down, because their lifestyle has changed, because their eating has changed. It kind of all works together, unfortunately, to cause that constipation. You are going to see a greater number of older patients use laxatives. regularly than just when they're constipated. So instead of saving those laxatives for when they've not had a bowel movement in 3 days, which is normal, by the way, we don't get upset or worried about someone not having a bowel movement until it is past that 3rd day. That is when they should consider using a laxative. But a lot of older people use laxatives every single day. Of aging people who actually are constipated, 2/3 have slowed passage in the distal colon and delayed rectal emptying, which also contributes, unfortunately, to that. Some of the most common causes of constipation in an older person are, of course, I said decreased physical activity, their change in diet, which usually is that they have a low fiber diet, side effects of medication we kind of already talked about, if they happen to have an inactive hypothyroid, or if they don't take in a lot of water, because in addition to their lifestyles changing, a lot of them also have things that are comorbidities that go along with it, like hypertension. So they may be on diuretics, which may actually help them, which may cause them, to get rid of more water, and they don't oftentimes want to take in more water because they don't want to spend more time in the bathroom. All right, how about culturally? One of the things that you'll hear oftentimes is that, especially, or that a lot of people will tell you that they are actually what they call lactose intolerant. Lactase is actually the enzyme that's necessary for the absorption of the carbohydrate lactose, which is actually milk sugar. The people that do suffer from lactose intolerance are going to suffer from abdominal pain, bloating, and flatulence or gas when milk products are consumed. The incidence of lactose tolerance is anywhere from 70 to 90% in African Americans, Asians, and in the Mediterranean group. Lactose intolerance in Caucasians is fairly low. It's actually only about 15% in them. So what is the subjective data that we want to be sure and ask? Well, we want to ask about their appetite. We want to know whether or not, again, that they've had any kind of change in their appetite. Have they had a loss in appetite? Has their weight changed? Have they gained or lost weight? Over how long of a period of time did they gain or lose this weight? Are they having any problems swallowing? Dysphagia is very common in individuals that have changes in their diet and that have abdominal issues. When did they first notice this? That's always important as well, as I say about everything, right? Food intolerance. Are there any foods that they can't eat? If they do eat them, what happens to them? Do they have an allergic reaction? Does it cause them to have heartburn? Does it cause gas or bloating, indigestions? And when they do have food intolerances, do they take antacids, and how often do they take them? Abdominal pain is a big one. A lot of times, asking a patient that has abdominal pain, one of the best ways to find out what truly is going on with them is to ask them to point to it. Ask them if it's just in one spot, or does it kind of move around in their abdomen? Again, how long have they had it? When did it start? How did it start? Is it constant? Does it come and go? Does it happen when you eat? What kind of a character does the pain have? In other words, is it cramping, like it's colicky, or is it like a pit, a burning in the pit of their stomach? Is it dull? Is it stabbing? Is it aching? I should mention too that abdominal pain, a lot of times, especially in women, is associated with their cycle, or the fact that maybe their cycle is not regular. Increased stress also causes abdominal pain. Overeating actually causes abdominal pain. Any kind of fatigue, nausea, and vomiting always causes abdominal pain just because of the soreness of those muscles. So we want to make sure that we ask them what makes the pain worse, of course. Does it make it worse when you eat? Does it make it worse when you take medicine, when you are in a certain position? And what have you tried to get rid of the pain? Whether it's medications, using a heating pad, or changing your position, whatever. Nausea and vomiting. Are they having any? How often do they have it? How much do they vomit? Is it their entire meal? Is it just digestive juices? So in other words, what color is it? Is there an odor to it? Of course, is there any blood in it? Nausea and vomiting that's associated, a lot of times, nausea and vomiting is associated with colicky pain, with diarrhea, with fever, and chills. If they do have nausea and vomiting in addition to these things, then there might be some sort of viral connection to this. And it's important that we know too what they ate in the last 24 hours. Were they at home? Were they at a restaurant? Was there anybody else in the family that's having the same symptoms that they are? Their bowels, how often do they have a bowel movement? Remember, every 3 days is pretty normal. In an older person, though, they're going to tell you that if they do not have a bowel movement every single day, that they think something is wrong. We do want to know, as far as their bowel habits are concerned, though, we want to know the color, we want to know the consistency, we want to know if they're having either diarrhea or constipation, and if they are, we want to know, of course, how long. Has this been a recent change for them? Have they just started having constipation or diarrhea? Do they use laxatives? And of course, which ones and how often do they use them? Abdominal history would include anything like gastrointestinal problems like ulcers, gallbladder problems, hepatitis or jaundice, even appendicitis, a hernia, whether or not that they've ever had any operations, and we would want to know whether or not they had any problems with them, whether or not they've had any abdominal x-rays or studies, and if they did, of course, what were the results. Medications, what medications are you currently taking? We want to know how much alcohol do you drink every day? We want to know each week. We want to know when the last time was that you had an alcoholic drink, because this significantly impacts not just the medications, but how it is digested in your system. We want to know whether or not they smoke, and we want to know how many packs per day, and we want to know how long in addition. All right. Additional history for infants and children. Of course, we want to know whether or not that they were bottle or breastfed. We want to know whether or not that, especially if they are currently being bottle or breastfed, how are they tolerating their formula or even their mother's milk? Are they trying new foods? And if they are they tolerating them well? How often do they eat? Do you feed them regular meals, or do you just let them eat whenever they want to? How do you feel about your child's eating problems? Because even at a young age, we know whether or not that they are either too high or too low on the growth charts. We know that when this happens, that we are to try to bring parents to be aware of this, so that they can go ahead and incorporate behavioral changes in their children. Some parents, and it's important to know this, believe that children that are a little bit on the chubby side, or that are healthy, as they like to call them, that's exactly what it is that they're healthy. They think that if they're carrying more weight, that they're healthy than children who are thin. And that is not necessarily the case, is it? We want to know exactly what their child has had to eat over a 24-hour period. We want to know what they had for breakfast all the way through the day, and we want to know whether or not that they have snacks. Does your child ever eat non-foods, such as grass, dirt, or paint chips? You can probably think of many times over the years, and even on TV and whatnot, that we've seen children making mud pies. And of course, and sometimes they actually do eat those things, or at least give them a try, right? They don't eat a whole lot of it, probably. Also, before I go on to adolescence, we want to know whether or not that they're having constipation, because this is important even at their ages. We want to know how often that they're going to the bathroom. We want to know how much water and how much juice is in that child's diet as well, because a lot of times this can be associated with constipation as well. If their child does have constipation, how are they treating it? Okay, and of course, we also want to know whether or not they're having abdominal pain. All right, how about in adolescence? Adolescence, a big thing for them is whether or not that they eat regular meals. Some of them will tell you that they don't ever eat breakfast, or they eat just one time a day. We want to know, in addition to that, what kind of snacks that they have. We want to know how many calories that they're taking in, because oftentimes we see one extreme to the other. We will see, especially young girls, that may have very little caloric intake throughout the day, and then we may see individuals who take in 3-4 times the amount of suggested calories per day. If their weight is less than body requirement, so if they are underweight, did they do this on purpose? Did they mean to lose weight? Did they do it by dieting? Did they do it by exercising? Or have they been sick for the last several months and they've had nausea and vomiting, or that their stomach gets upset every time they eat, so they're just not eating anymore? We need to know why that they've lost weight. We need to know why, if that's the case, why they've gained weight as well. We want to know whether or not that they're having issues with being tired or even with hunger. We want to know, what do they think of their body? In young adolescents, especially if they happen to be carrying more weight, and we see it more in the midsection, some adolescents respond to the way that they look differently, of course. How healthy that their self-esteem or that their body image is going to determine that. And we need to know that as healthcare professionals so that we can decide how we are going to treat them if there are issues with that. We want to know how active they are. We want to know whether or not that the weight loss that we might be seeing, whether or not that it's associated with any other body change. Are they having irregular periods? Is this because that they've lost so much weight? And we want to know what their parents and friends actually say to them about their eating. I had a father when I was growing up that on a regular basis made comments about the kinds of food that I ate or that my sister ate, telling us that we didn't need to eat that, it was going to make us fat, or that it wasn't healthy for us. When in reality, most of the foods that we ate weren't at all unhealthy because we didn't eat them in large amounts. How about in aging adults? Additional history that we want to gather for aging adults is we want to know how they get their groceries and how their meals are prepared. Do they do it? Do they have someone come in and do it? And do they eat alone, or do they share meals with others? Aging adults that eat by themselves tend to eat a lot less, and they don't generally eat as healthy a meals. They may open up a can of beanie weenies, or they may open up a can of Vienna sausages and eat them with nothing else. When they eat with others, whether it's family or with its individuals in their same age group, they tend to eat healthier, and they do tend to eat more. We want them to tell us exactly what they've had to eat over a certain amount of time. Again, we want them to tell us starting with breakfast and throughout the day. A big one for aging adults is we want to know about dysphagia with them. Are they having any problems swallowing these foods? Do they have to chew them longer? Are they having issues with the taste of their foods? Have they stopped eating foods because they're having problems with digesting them, or that they just don't taste right to them anymore? And we want to know what they do right after they eat. Do they walk? Do they take a nap? Do they sit up? Do they lay down? Because all of these can contribute to the way that food is processed as well. All right, so now we're ready. We know what we're supposed to be looking for all the different age groups. Now we want to make sure that that as we get ready to start our examination, we want to make sure of a few things. We want to make sure that when we are getting ready to perform this exam, that the room is well lit. We want to be able to see the abdomen. We want to be able to see all of the abdomen. And the only way that we're going to be able to do this, of course, is to fully expose the abdomen, but please make sure that you are providing for privacy for them. Make sure that you're draping the genitalia. Make sure that you're draping female breasts. You want to make sure that the room is warm. The patient should actually be supine, or laying down with their arms at their sides, because if they have their arms over their head, it will actually cause their abdominal muscles to tense more. So you want them to put their arms at their sides. You can put a pillow up underneath their arms if you like, and you can also let them bend their knees if it happens to be more comfortable for them. I guess that's it for... Okay, the contour of the abdomen. This is something that I want you to know too. We want you to know the difference between a flat abdomen, a scaphoid abdomen, a rounded abdomen, or even a protuberant abdomen. A flat abdomen is something that you're going to see mostly in young, in a young adult, or someone that is fairly in decent shape. So it might be nice and fat. Usually women that are going to be pre-baby will have flatter stomachs. Women that have had babies may have more of a rounded stomach. Individuals as they age, getting that spare tire, may have more of a rounded stomach. Scaphoid, we see this in an individual that is very, very thin. We may see this in an individual that is very athletically fit. And protuberant, we see this in someone who is very, very overweight, obese, morbidly obese, someone as they're aging, again, that spare tire, but this is still going to border on obesity. And who else will we see a protuberant stomach in? Yes, a pregnant woman, right? We want to make sure that when we are looking at the contour of the abdomen, that we're standing on the right side of that patient, and we want to look down on the abdomen. Then we want to get down and we want to stoop, or we want to gaze across the abdomen to look at the way that it is shaped. Your head should be slightly higher than that abdomen. You're going to determine their profile from the rib margin to the pubic bone. Okay, so the bottom of the ribs all the way down to the pubic bone. That contour is actually going to describe their nutritional state, and it normally ranges, again, like I said, from flat to rounded. Inspecting the abdomen. I said already that you would do that you would stand on the person's right side and whatnot, determine their profile from the rib margins. But what about the symmetry? We want to make sure that we shine a light across that abdomen, both towards you and away from you, or you can actually shine it lengthwise across the person, and it should look smooth. You shouldn't see this. It should be symmetrical on both sides. One side should look pretty much the same as on the other side, right? Auscultate. We know that inspecting, of course, is the first thing that we're going to do, but with the abdomen, instead of palpating or percussing, we're going to auscultate. So we're going to listen first. We are going to make sure that we listen in all four quadrants. We want to note the character and the frequency of the vowel sounds. So we want to know, are they having vowel sounds at an increased rate or at a decreased rate? Would we call them hyperactive? Would we call them hypoactive? We want to make sure that depending on the time that is passed since the last time that they ate, we would kind of be anticipating what we might be hearing. If they haven't ate for a long time, we may expect that we will hear more active vowel sounds. Vowel sounds actually originate from movement of air and fluid as they are going through the small intestine. That is what's making that kind of a bubbling noise when we hear it. Vowel sounds are high-pitched, so they sound like timpani when we listen to them. They're gurgling. Sometimes we refer to them as cascading sounds, so that they kind of sound like that they are in higher pitch going down. They occur irregularly, anywhere from 5 to 30 times per minute. Don't try and count them. There's no need, as long as that you hear them. Making sure, of course, that we said, how often do you listen, or how long, do you listen for vowel sounds? Remember that we said that you listen for vowel sounds. If you need to, you may listen for a full 5 minutes in each quadrant to determine whether or not that there are truly vowel sounds. So if you have to listen to vowel sounds, you may actually have to listen for a total of 20 minutes before you can determine that an individual does not actually have vowel sounds. One type of hyperactive vowel sound that's really common, that is what we describe oftentimes as my stomach growling because I haven't eaten anything in a long time, is called borborygmy. This is actually normal, but borborygmy is going to mean that they actually have a little bit more active sounds. And again, we often refer to this as being their stomach growling. Okay. You're also going to listen or auscultate the vascular sounds, aren't you? We're going to listen to the renal arteries. We're going to listen to the abdomen. We're going to note whether or not that we hear any kind of bruise over the aortic, over the iliac, the femoral arteries, the renal arteries, and these are going to be especially common in people that have hypertension. Usually we should not hear any of this, right? We should hear nothing when we listen to that. And we're going to listen to them with the bell or the diaphragm. The bell, right? Okay. Percussion is the next thing that we're going to do. We want to, we said that in the abdomen that we are going to hear mostly tympani. We should hear in the liver and spleen areas, we should hear dullness. right? Because it is going to be solid there. We're going to percuss to assess the relative density of the abdominal contents to see whether or not that there's a lot of stool built up, whether there's a lot of gas built up, whether or not we're hearing fluid. It's also done so that we can locate the organs, and it helps us to screen for any kind of abnormal fluid or masses. We're going to first percuss really lightly in all 4 of the quadrants to determine any kind of prevailing tympany and dullness. And then we're going to move clockwise. Tympany should predominate because air in the intestines rises to the surface when the person is supine. Okay. Palpation. This is our last step, right? Palpate, we are going to palpate the surface and we are going to palpate deeply. When we perform palpation, what we are trying to determine is we are trying to judge the size, the location, and the consistency of certain organs. This is helping us to screen for any kind of abnormal mass or any kind of tenderness that that individual might have because of a disease process. Because most people are naturally inclined to protect their abdomen, you need to use additional measures to enhance complete muscle relaxation for these individuals. You may have the person actually bend their knees. You may keep your palpating hand low and parallel to the abdomen so that they can't see it at all the time. You want to talk quietly in a lower voice to them. You may even actually ask them to think about something else while that you're palpating the abdomen, because it actually will truly help them to. All right, so palpating the liver. When you are palpating the liver, we know that we are going to take your left hand, because you're on the right side of the individual, right? And you're going to place it under the person's back to help to support those abdominal contents. That's the reason that we're doing it. Then we're going to take our right hand and we're going to place it on the right upper quadrant with our fingers parallel to the midline. Okay, so our fingers are pointing towards midline or towards the center of the abdomen. You're going to ask that individual to take a deep breath, and as they are taking that deep breath and holding it, you're going to push deeply down and under that right costal margin. Okay, so down and up a little bit. When they take that deep breath, you may at that particular time actually feel the very edge of the liver, but again, oftentimes you will not. When you actually push down deeply, you're going to ask them to release that breath. And oftentimes you'll find that, like we said, that the liver is not palpable, or in some cases you may actually feel it slip through your fingers. Okay, so we're done with the liver. Now let's move on to the spleen. Normally, the spleen should not be palpable. If it is generally going to be about 3 times its normal size before we're actually able to feel that. Again, you're going to want to be on that right side. You're going to actually have the patient kind of lift up for some support. You're going to take that left hand, you're going to reach across them, and you're going to take your right hand and you are going to move obliquely on that left upper quadrant with the fingers pointing towards the left axilla. So instead of them pointing in, they're going to be pointing out, right? And that's actually going to be just inferior to that rib margin. You're going to do the same thing that you did on the other side. You're going to push your hand deeply down under that left costal margin. You're going to ask that person to take a deep breath. You should feel nothing, and you should certainly feel nothing firm. How about when we are assessing an infant? When it comes to an infant, it's going to be a little bit trickier because their abdomen is more what we call protuberant. It's going to stick out. This is probably the only time in their life that having a protuberant belly is actually okay. And this is just because those abdominal muscles haven't fully developed yet. Their skin is actually going to contain kind of a fine superficial venous pattern, so sometimes you might see that the veins actually on their abdomen might be a little bit more visible and, like I said, kind of a bluish color. If you are assessing a baby that is still within that neonatal period, that first 28 days, you need to make sure that you look at the umbilical cord. At birth, it's actually kind of a white color, and as I said earlier, it's going to contain 2 umbilical arteries and 1 vein. It's usually surrounded by a substance called Wharton jelly, and it looks a lot like, it really does look a lot like jelly, but it is actually connective tissue. Usually it dries up within about a week. It gets hard, and it will eventually fall off within a 10 to 14 day period. When you're auscultating, most of the time when you auscultate an infant's abdomen, it's going to sound a little bit, it'll sound a little bit metallic, has kind of like a metallic tinkling of peristalsis, but it really won't be a whole lot different than what you hear in an adult. Percussion, you're still going to hear that tympany over the stomach, but you're going to hear it more over the stomach than you do in an adult, because infants actually swallow a lot more air when they're eating. Okay, you're still going to hear that dullness over the liver, and of course, we're not going to actually percuss the spleen because of the immature immune system. And remember that the abdomen is going to sound tympanitic. So it's going to have that tympany sound. Palpation, it may be a little easier for you to be able to palpate a baby's abdomen, forcing them to relax their abdominal muscles by flexing the baby's knees with one of your hands and then actually using the other hand to be able to palpate the abdomen. In an older adult, you will inspect just like you would on the average adult, but you may notice, of course, that they're going to have increased deposits of subcutaneous fat, especially on the abdomen and the hips. Why? Because of that redistribution thing, right? As we get older, we know that that fat actually pulls away, moving down towards the center of our bodies. Their musculature is actually going to be thinner, and it's going to have less tone. Because now, instead of them being underdeveloped, they're actually not developed because of non-use. So they're going to start to atrophy. They're going to have, because of that thinner, softer abdominal wall, again, in an older adult, just like in a child, a lot of times their organs are going to be easier to palpate. And that's in the event that they are not obese, because if they are obese, they will still be very difficult to be able to palpate. The liver is easier to palpate in an older adult. Normally, you will be able to feel that liver edge at or just below that costal margin. With distended lungs and a depressed diaphragm, the liver can actually be palpated even lower. So if you have an individual that has COPD, you might actually feel them in a little bit different location. And the kidneys are usually easier to palpate too. So what about documentation? Subjective, we're going to, of course, look at their appetite. We're going to record whether or not that they've had any issues with dysphagia, whether or not they've had any food intolerances, whether they're having any pain, nausea, or vomiting. We want to know about their bowels. We're going to record that. We're going to record any kind of medications, whether they are prescribed or whether they are over the counter. And we want to know, of course, about their family history as far as abdominal disease is concerned, whether they've had any injuries or surgeries. And we want to know about the last 24 hours, what they've had to eat. Objectively, we're going to, of course, as we said earlier, we're going to inspect, auscultate, percuss, and palpate. We're going to note the contour of the stomach. We're going to note the symmetry of it. We're going to note whether or not that we see any striae, any scars, or any lesions. Auscultation, we're going to record bowel sounds. We may record bowel sounds present, bowel sounds active, but we also want to know that they are present or active in all 4 quadrants. We also want to note that we do not auscultate any bruits in any of the renal arteries. Percussion, we should be hearing tympany, and we want to say that we have actually heard tympany in all 4 of the quadrants. We want to make sure that we record the liver span. Remember that liver is supposed to be what? 6 to 12 centimeters or 2 to 4 inches, right? We want to note whether or not that there is a splenic dullness. Okay, so we should hear dullness in that area when we percuss because of the organ being there. And we want to know exactly where that we are hearing that dullness. When we palpate, we want to make sure that the abdomen is soft, that they're not having any organ megaly. So in other words, we can't feel the spleen, we can't feel the liver. We want to make sure that there aren't any masses or tenderness. Healthy abdominal bowel sounds, or healthy abdomen, and bowel sounds are present. And make sure that you go back and that we look again, of course, at the abnormals, right? We want to, especially related to abdominal distension, because there are a number of things that could be causing that. Could be because they're obese, could be because they have excess gas. What's ascites? Ascites, we know that this is fluid buildup in the abdominal cavity, usually related to liver disease or congestive heart failure. An ovarian cyst, which may be related to female problems if they're pregnant. We're going to notice that they have abdominal distension. Now, if they're early in their pregnancy, then it may not be quite as obvious, right? We want to know whether or not that they have a large amount of stool that has collected. If they are having problems with constipation on a regular basis, their abdomen may be distended because of that. And of course, anything that we might suspect as being a tumor. An umbilical hernia. This is in a small child, in a 2-year-old or up to a 2-year-old, from a newborn up to a 2-year-old. Usually they will resolve. Usually we see, you may just see this as a bulging of that umbilicus at rest, or you may not actually see it until they get mad and they start to cry. So make sure that you go back and you look at the different types of hernia and what we call diastasis recti, which is a separation of those abdominal muscles, which we see in children, usually in infants when they're first born, and we see this in women who have had babies as well. A lot of times those abdominal muscles will separate. All right, we want to know about hypoactive bowel sounds, and we want to know about hyperactive bowel sounds. Okay. Moving on to the musculoskeletal system. We want to we're not going to spend tons and tons of time on the musculoskeletal system. I'm not going to lie to you about that. Just like it is more in abbreviated form in our book, in our checkoffs, we're not going to spend a great deal of time either going through the musculoskeletal system as well. So, all right, moving on. All right, components of the musculoskeletal system. We know that the skeleton is a bony framework of the body. So, of course, this simply meaning what? That this is where our bones are, right? We have 206 bones. They support our body just like posts and like the beams of a building. We have both bone and cartilage that are in specialized forms of connective tissue. We know that bone is very hard, that is rigid, and is very dense. We know that cells are always turning over and that we are remodeling as we age. Remember that joints or articulations, which is another way that we refer to them sometimes, are places of union of two or more bones. So this is where that the bones connect, right? And tendons are connecting muscle to bone. Okay, let's review joints just for a second. Let's talk about non-synovial joints and synovial joints. Remember that non-synovial joints are where bones that are united by fibrous tissue or by cartilage. So they're not going to be able to be moved. This would be like the sutures in your skull, and then you can have slightly movable, which would be like, of course, your vertebra. Synovial joints are going to move freely, and this is because the bones are separated and they're enclosed in what we call a joint cavity. Within that cavity is a lubricant, or what we call synovial fluid, and the synovial fluid actually allows sliding to occur. This is what actually allows that kind of movement. Muscles. Our muscles account for 40 to 50% of our body's weight. So, this is why in an individual who is physically fit, who does a lot of strength training, that they will usually weigh more than someone who does not do a lot of weightlifting, because muscle weighs more than fat. Okay, when those muscles contract, they produce what we call movement. This is what allows our muscles and our parts of our body to be able to move. Muscles are of 3 different types. We have skeletal muscle, we have smooth muscle, and we have cardiac muscle. Cardiac muscle is self-explanatory. It is the muscle of the heart. Smooth muscle is going to be in areas like our respiratory tract, in our GI tract, and of course skeletal is what the majority of our muscle is composed. Skeletal muscle movement is going to include flexion, which of course is bending the limb at the joint. Okay, extension, which is straightening it. Okay, so we can bend our wrist, we can straighten our wrist. So bending it would be flexion, extending it would be straightening it. Abduction would be moving the limb away from the midline of the body. So if we were abducting our leg, we would move our leg out away from our body. Okay, adduction, think about it as adding towards the midline of your body. So adduction is actually moving that body part towards the midline of your body. Pronation, which is turning the forearm so that the palm is down. Supination, of course, is the palm is going to be up. And then you have circumduction, which is moving the arm in a circle around the shoulder. So it has almost a 360-degree movement. Make sure that you know what these muscle movements are. We also have what is called inversion, which is moving the sole of our foot inward at the ankle, so moving it towards the inner part of our body. And then you have eversion, which is actually moving the sole of that foot outward at the ankle. Rotation is what we do with our head, moving our head around a central axis. This is called rotation. Protraction, this is moving a body forward and parallel to the ground. So like we could move our shoulders forward. Retraction would be moving that body part backward and parallel to the ground. So when we move our shoulders forward, it's protraction. When we move them back, it is called retraction. Elevation, which is raising the body part, which could mean that we are shrugging our shoulders. And when we lower those shoulders back down, that would be referred to as depression. You can look at those at your leisure. While we were talking about joints, I did forget to mention the temporal mandibular joint. Remember that this is how articulation works between the mandible and the temporal bone. You can actually feel it in depression anterior to the tragus of the ear. The TMJ actually permits jaw function of speaking and chewing, and it allows 3 different motions. It allows its hinge action to actually open and close the jaws, gliding action for protrusion and retraction, and then gliding for side-to-side movement of the lower jaw. Okay, infants and children as far as developmental competence is concerned. Remember that by 3 months that the fetus actually has formed the skeleton, has actually already formed a skeleton of cartilage. Bone growth, remember, it continues rapidly through infancy and very steadily in childhood, although remember it does slow down a little bit until they get to be an adolescent, and then of course we have that growth spurt again. Remember that children go longitudinally, and this continues until the epiphysis or the growth plates, as we refer to them, close. And usually the last closure doesn't actually occur until about the age of 20. Although skeleton contributes to both linear growth, muscles and fat are significant for weight increase. So that's good to keep in mind too. Remember that in infants and children that you're going to see increased levels of circulating hormones. Sorry. This should be pregnant women. In pregnant women, you're going to see increased levels of circulating hormones that are going to cause that increased mobility in joint. Remember that women produce what? Relaxin in order to be able to allow the passage of the baby through the birth canal. This is also going to result in increased mobility in the sacroiliac and the sacrococcygeal, which is specifically where that baby is going to come through. Actually the symphysis pubis and the pelvis itself are going to relax, and it is going to contribute to noticeable changes in the maternal posture. That's why with them a lot of times that they have what we call sway back, right? They have lordosis. The most characteristic change is progressing lordosis. As they get further along in their pregnancy, they will have more and more of that kind of a look. And it just actually compensates for the enlarging of the baby. This, however, is going to put more strain on their lower back muscles. So they're going to complain about having more low back pain than when, of course, they are not pregnant. It also causes anterior flexion of that neck, and it will cause them to slump in their shoulders because of that lordosis, which is also going to continue to result in postural changes. In an aging adult, what are we going to see? Well, remember that we said that bone remodeling is constant. It is still the case for someone that is aging in years. However, after age 40, resorption actually occurs more rapidly than deposition. So meaning that they're not having as many new cells, unfortunately. The net effect of that is going to be that they're going to have a loss of bone density, which will probably result in osteoporosis. Postural changes are also going to be evident in an aging adult. This is because of the loss of height and because of the bone resorption. Older adults are going to have a distribution of subcutaneous fat that changes throughout life. The contour is going to be different even if the weight is the same as when they were younger. All right, subjective data. What kind of subjective data are we going to gather? Well, we know that we're going to ask them about their joints. Of course, what are we going to ask them? We're going to ask them whether or not they're having any pain or any problems with their joints. We want to know where that they are having the pain. We want to know which joints it might be affected. Is it on one side or is it on both sides? We want to know the quality of the pain. So in other words, we want to know what it feels like, whether it's aching, whether it's stiff, whether it's sharp or dull. Is it a shooting type of pain? And we want to know the severity. How strong is the pain? Using that scale, that pain scale that begins at 0 with no pain and 10 being excruciating pain. We want to know the onsets. We want to know when it started, and we want to know the timing of it. Is there a certain time of the day that it occurs? How long that it lasts, and how often does it occur? Are all timing things that we want to know about joints. We want to know whether or not that it's aggravated by movement, whether or not that it gets better with rest or changing position. Is it affected by the weather? Does certain medications help to improve their pain? Do they use heat or ice treatments to it? Do they have any stiffness in their joints? Do they have any swelling? Do they have any heat or redness in those joints? And what activities give you problems with those joints? What about muscles? What are we going to ask them about their muscles? Well, we want to know whether or not they're having any problems, of course, like pain or cramping. We want to know which muscles it affects. We want to know that if it's in their calf muscles, is it pain that's related with walking? And does that pain go away with rest? Do their muscles ache, and is it associated with fever, with chills, or the flu? Do they have any weakness in their muscles? And what's the location? Where's the weakness? How long have they noticed the weakness? What about bones? Of course, we want to know whether or not they have any pain in their bones and whether it's affected by the movement of those areas. Do they have any deformities of the bones or joints? Have they broken anything that didn't repair well or that didn't repair after an injury or trauma? And does it affect their range of motion? In some individuals, if a break or trauma does not heal correctly, they may have limited range of motion in that area. Have they had any accidents or trauma that has affected the bones or joints, like fractures, strains, sprains, or even dislocation? If that is the case, then which bones did it affect? Which joints did it affect? We want to know when it occurred. Did they receive treatment for it? And if they did, what kind of treatment? And whether or not that currently they have any kind of problems or limitations because of that. What about ADLs? A lot of times when it comes to the musculoskeletal system, we are looking at ADLs. That's a lot of the reason that we look at the musculoskeletal system, period, is to be able to assess those ADLs. We want to know whether or not that any of those joints, any of those muscles, any of those bones create any kind of limitations on their ADLs. If it does, we want to know specifically which ones. Do they have problems with bathing? Do they have problems with toileting? Do they have problems with getting dressed? Simple things like that. Are they having problems with being able to groom? Can they shave? Can they brush their teeth? What about eating? Can they prepare their meals? Can they pour liquids? Can they cut up their foods or bring food to their mouth, and are they able to drink without assistance? Their mobility. Are they able to walk unassisted? Can they get up downstairs? Can they get in and out of the bed? Can they get out of the house? These are all part of ADLs. And let's not forget communicating as well. Are they able to talk clearly? Are they able to use the telephone? And are they able to write? All of these are related to musculoskeletal. Now, lastly, what about self-behavior? Are there any kind of occupational hazards that could affect your muscles and joints? Do you do the kind of work that involves heavy lifting? Do you do repetitive motion, or is there chronic stress that occurs to your joints? And have you done anything about it as far as to alleviate some of this? Have you decreased your work hours? Have you used braces or assistive devices to relieve some of that stress? We want to know about their exercise program. We want them to describe the type of exercise, the frequency, and whether or not that they actually warm up before they do this program. Do they have pain when they exercise, and how do they treat it when they do? We want to know whether or not that they've had any recent weight gain, and we want to know about their daily diet. All right. Additional information. What would we ask about infants and children? Well, we want to know, when it comes to infants and children, whether or not that there was any kind of trauma that occurred to the infant during the labor and delivery. Did the infant come head first? Was there any need for forceps? Did the baby need to be resuscitated? Did the baby meet their motor milestones achieved at the same time as their siblings or at their age mates? Has the child ever broken any bones, had any kind of dislocations? And if they have, how have they been treated? Have they noticed any kind of bone deformities like spinal curvature? Any kind of unusual shape of the toes or feet are another thing that we see oftentimes when it comes to bone deformity. What about for an aging adult? We want to know, again, remember I said that when it comes to musculoskeletal, a lot of times what we're truly assessing is an individual's capabilities in order for ADLs to occur. Using functional assessment history questions to elicit any loss of function, self-care deficit, or safety risk. We are going to ask them questions about their ability to do ADLs and whether or not that they have lost any function, whether they can still care for themselves, or whether or not that their lack of ability is causing any kind of safety risk. We want to know whether or not they've had any changes in weakness over the last few months. Have they had an increase in falls or stumbling, and do you use any kind of mobility aids to help you get around, like a cane or a walker, or of course even a wheelchair? All right, so the purpose of the musculoskeletal examination, as I've said 3 times now, is to assess function for ADLs and to screen for abnormalities. You already will have considerable data regarding your ADLs through the history that you get from them. You can note additional ADL data as the person goes through the motions necessary for examination. For example, when they walk into the room, their posture, how the person sits in the chair. Do they sit upright? Do they slump over? How they get up from the chair. Are they able to do it without assistance? Do they get up very slowly? Can they get right up? Whether or not that they can manipulate small objects, such as a pen, to be able to sign their name, and how they get up from a supine position. All of these things are huge indicators as to whether or not that their musculoskeletal system is in good repair. So we want to make sure that prior to beginning the assessment that we make sure, just like always, that we make the person comfortable. We want to make sure they're comfortable before the exam and during the exam. Again, we want to allow for privacy. We want to make sure that we're not needlessly exposing parts of the body that we shouldn't be. Take an orderly approach. Just like we do our assessment with musculoskeletal, same thing. I want you to start from the head and go down to the toe. We should go from proximal to distal, so nearest to furthest, and from midline to outwards. So starting with the center of the body and moving outwards. Support each joint at rest. When you are testing range of motion, when you are testing strength, it is important that you support those joints when they're at rest. Muscles must be soft and they must be relaxed in order to assess not just the joints accurately, but DTRs as well. Take care when you are examining any kind of inflamed area. Make sure that that individual is not experiencing any additional pain because of the way that you happen to be assessing them. So you don't want to roughly manipulate we don't roughly manipulate the area, causing them to maybe have muscle spasms or even causing additional pain. Compare the corresponding paired joints. So if you're checking a joint or an area that is damaged or that the patient is complaining about, make sure that you check the other one as well, okay, to make sure that you have a baseline to compare it to. So order of examination. Of course, we're going to inspect, we're going to palpate. Inspection, we're going to notice what? The size and the contour of the joints, of the muscles. We're going to inspect the skin and the tissues over the joints. What are we going to look for? We're going to look for color, we're going to look for swelling, and we're going to notice whether or not there are any kind of masses or deformity. The presence of swelling always signals joint irritation. If you see swelling, you know that there is something going on with that joint. Palpation, we're going to palpate each joint, including the skin. We want to know about the temperature. We want to know about the muscles. We want to know about their tone, their size, their symmetry. We want to know about bone articulations. Are we hearing crepitus when we are moving them through range of motion? Are they able to move through range of motion smoothly? We want to look at their spine. We want to make sure that their spine is straight. We want to look at their gait. Are they able to walk without assistance? Are their steps very slow and measured, or are they able to walk normally? Muscle testing. When we test muscles, we want to make sure that we test them both passively and actively. Passively meaning that we take them through the motions, okay, and actively meaning that they are actually doing that. The muscle strength should be equal. We rate muscle strength anywhere from 1 to 5 as far as muscle testing is concerned. Let me think. So if you have normal muscle strength, you would rate that this individual has 5 out of 5 muscle strength. All right, documentation. Subjective, again, we're going to talk about joint pain. We want to know about stiffness, swelling. We want to know whether or not they have limitation, meaning what? That they're not able to go through the motions, that they don't have muscle strength. What are the limitations that they have? We want to make sure that they're not complaining of any pain or weakness. We want to know whether or not that they have reported, or we want to record whether or not that they have told us that they've had any kind of bone trauma or deformity. We want to know whether or not that they are able to do their ADLs without any kind of physical limitations, and whether or not that they can do it without assistance. We want to know whether or not that the occupation that they are involved in, or this is what we're going to document, of course, that their occupation involves no musculoskeletal risk factors. But if it does, then we record that, right? Exercise pattern is a brisk walk 1 mile 5 times a week, as simple as that. Objective, this is what we see. Are the muscles in the joint symmetrical? Do we see any swelling? Do they have any masses or deformity? Is their spine straight? Do they have any tenderness when we palpate their joints? Do we feel any heat or swelling or masses? Do they have full range of motion? Is their movement smooth? Are we noticing any kind of crepitus or tenderness? And what their muscle strength is. The assessment should be that the muscles and joints appear healthy and functional. All right, abnormals. Abnormalities affecting multiple joints. Remember that I want you to be sure that you understand inflammatory conditions including rheumatoid arthritis and ankylosing spondylitis, degenerative conditions like osteoarthritis and osteoporosis. These are only the main joint diseases I want you to know, but you know that you're responsible for those that are discussed in the book. All right, last chapter, guys. Neurological system. Remember that our neurological system or our nervous system is divided into 2 parts. We have the central nervous system, which includes what? The brain and the spinal cord, right? And then we have the peripheral nervous system, which includes all the nerve fibers outside of the brain and the spinal cord. We have 12 pairs of cranial nerves. We have 31 pairs of spinal nerves and all their branches. Those spinal nerves actually carry sensory, or what we call afferent messages, to the central nervous system from those sensory receptors. And then you have the motor or efferent messages from the CNS. They go to the muscles and to the glands, as well as the autonomic messages that govern the internal organs and blood vessels. So when we are doing a neurological assessment, we are assessing whether or not that the CNS, that the afferent and the efferent portions of our CNS are working correctly. So we're checking sensory and we're checking motor differences, right? Okay, so that having been said, oh, I forgot to move forward. Sorry, guys. The cranial nerves, let's look at them first. The cranial nerves enter and exit the brain rather than the spinal cord, right? Cranial nerve 1 and 2 extend actually from the cerebrum. Cranial nerves 3 through 11 extend from the lower diencephalon and the brainstem. The 12 pairs of cranial nerves supply primarily the head and neck, except for the vagus nerve, which travels to the heart, the respiratory muscles, the stomach, and the gallbladder. All right, what number is the vagus nerve? Number 10, right? All right, we said that we have 31 pairs of spinal nerves that actually arise from the length of the spinal cord and that they supply the rest of the body. They're named for the region of the spine from which they exit, so where they come from. You have 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and then 1 coccygeal. You have mixed nerves that contain both sensory and motor fibers. Remember I said that, both afferent and efferent. Each of them innervate particular segments of the body. And then you have dermal segmentation, that is cutaneous distribution of the various spinal nerves. So this is how that we are able to feel pain, how we sense, or the sensory portion of it. In infants, the neurological system is not completely developed at the time of birth. Their movement is directed primarily by primitive reflexes. Remember, we talked a lot about that they have like the moral reflex, the startle reflex. We talked about several of those, right? Those are what we call primitive reflexes. Most of the time, as their neurological system develops and becomes more completely intact, those reflexes actually go away. So the persistence of those primitive reflexes is an indication, if they still have them, that the CNS is actually not working the way that it is supposed to. All right, sensory and motor development are going to proceed with gradual acquisition of myelin that is needed to conduct most impulses. So it's myelin they're really lacking at the time that they're born. So as their bodies develop more myelin that covers these nerve endings, their sensory and their motor development will actually become more intact. As myelinization develops, the infant is going to be able to localize stimulus more precisely and to make more accurate motor responses, like being able to pick up things, being able to walk, all of those kind of things. Those are all associated with that myelin. All right. In an aging adult, we're going to see atrophy with a steady loss of the neuron structure in the brain and the spinal cord. People over the age of 65 show signs that in the younger adult would be considered abnormal. And that is because of this loss of the neuron structure. They're losing muscle bulk and their loss of muscle tone, especially in the face and neck and around their spine, that decreases their muscle strength. They're having impaired fine coordination, so having difficulty holding a pen or writing with it, holding utensils, those kind of things. Even the agility and the loss of vibratory sense at the ankle, or even an absent Achilles reflex. This is all normal in someone that is actually over the age of 65. Pupillary miosis, irregular pupil shape, and decreased pupillary reflexes are also included in being fairly normal for an older adult. All right, so subjective data. What are some of the things that we are going to look at? One of the big things when it comes to neurological that we look at is headaches. We want to know whether or not that an individual, not only do they have them, but if they do have them, we want to know how frequent they are and how severe they are. Do they keep them from going to work? Do they have to take medication? Does it get better if they just lay down and rest? where do they have the headaches? Are they having it in the front portion of their head? Is it in the back portion? And do they seem to be associated with anything? Students will tell you that when they're under a lot of stress for studying, that they tend to have stress headaches. That's pretty common. Um, if you've had a head injury or a brain injury, we also want to know about that. If they've had one, we want to know where it occurred and we want them to describe it to us. Did they lose consciousness? And if they did, we want to know how long they lost consciousness for. Dizziness or vertigo, what is that? That lightheaded swimming sensation, like you're feeling kind of faint, right? Are they having that? When did they notice it? How often does it happen? Does it occur with certain activities or when you change your position? Do you ever feel specifically that rotational spinning sensation, which is what? That's the vertigo, right? Um, do you, a lot of times, does it come on suddenly or is it gradual? Vertigo is going to affect what? Cranial nerve number 8, which is that vestibulocochlear nerve, which is that medullary portion of the ear. All right, how about seizures? Have they ever had seizures? When did they start and how often did they occur? Do they know when they're about to have a seizure? Where in your body do the seizures start? Do your seizures travel through your body or do they occur on just one side or on both sides? Do they have any associated changes with them? Like, does their color change in their face or in their lips? Do they lose consciousness? Do they lose control of their bowel and bladder? Are there any kind of precipitating factors or things that bring on those seizures? Certain activities or stopping medication, any kind of fatigue or being under a lot of stress are also common causes for seizures. Do they have what's called a postictal phase, which means that after they have a seizure, they fall asleep, they may have confusion, they may have weakness or a headache or even muscle aches. That is called a postictal phase. And what do they do to cope with their seizures? Has it affected their daily life? Are they able to work or have they become disabled because of it? Tremors is another one that we look at that we want to know about, especially as a person ages. We want to know whether or not they have any shakes or tremors in their hands or face and how long that they've had them. Do they seem to grow worse with anxiety? Do they get worse when you rest? And do they affect your overall daily activities? Weakness, is it generalized or is it local? So specifically, does it affect one area or do you have generalized weakness, meaning that it affects all of your body? Does it occur with certain movements? Getting up, laying down, turning a certain way? Is it hard to get up out of a chair or reach for an object? With distal or small muscle weakness, it would make it hard for them to open a jar, for them to write or use the scissors, or even to walk around without tripping over things. What about balance issues? Do they have any problems with balance when they're walking? Have they had any falls? Which way did they fall? Did they fall forward or did they fall backwards? Do your legs seem to give away? Are you more clumsy than you used to be? Numbness or tingling? Does it ever feel like there's a whole bunch of pins and needles that are in your body? And does it occur with any type of activity? Difficulty with speech or with swallowing? Do they have problems with swallowing liquids or solids? Have they ever experienced excessive saliva or drooling? Or do they have problems forming words or saying what they mean to say? Sometimes patients that have issues with um, difficulty speaking, it's almost like that they're missing the connect neurologically. That that the connection to be able to say what they're thinking just isn't there. And we want to know, of course, when they noticed it and how long that it lasted. Um, and we also want to make sure that we're asking them things like whether or not that they've smoked, whether or not they've had a stroke, whether or not they've had any kind of spinal cord injury, whether or not they had meningitis or encephalitis, any kind of congenital defects, or if they happen to be alcoholics. All of these are going to be neurological related to, or I shouldn't say always, but they can have neurological effects to them. Subjective data, including environmental and occupational hazards, is one last thing that we want to ask about. Um, what kind of work do they do? Are they a farmer that's been exposed to insecticides? Do they work with organic solvents or do they work with lead? Are they taking medicines now? And if they are drinking or smoking, we want to know how much. We want to know how often. We want to know if it's every day or just on occasion. Okay. All right. Developmental as far as infants and children are concerned. We want to know whether or not that mama had any health problems while she was pregnant. Did she have any kind of infections or illnesses? What were the medicines that she took if she did? Whether she had toxemia, hypertension. Did she have high blood pressure during her pregnancy? Was she spilling protein into her urine, which actually resulted in her becoming preeclamptic or eclamptic? Alcohol or drug use, or whether or not she was diabetic. Was the infant premature, or did the mother go full term? What was the baby's birth weight, and was there any kind of birth trauma, and did the infant breathe immediately? These are all things that would be important for us to know. We'd also want to know whether or not that the mother might know what the APGAR scores are, and that is just whether or not that they cried spontaneously, whether or not they breathed spontaneously. It's a score that are given to babies upon birth and then 5 minutes later. What about for an aging adult? In an aging adult, we want to know specifically about things like dizziness. We want to know, does it occur when they're first sitting or standing up, when they move their head, when they get up and walk, after they eat? Does it occur with any kind of medications? For men, we want to know whether or not that they feel faint when they get up in the middle of the night to go to the bathroom. How does the dizziness affect your daily activities? Are you able to drive safely? Can you move around in your house safely? And what safety modifications have you applied at home? In other words, have you had to put up railings? Have you had to put up bars in your bathtub in order to be able to get in and out of it safely? All right, objective data. So what are we going to be doing when it comes to actually doing the assessment? Well, we want to make sure that, of course, that we prepare properly first. So we're going to perform the screening neurological examination on well persons with no significant findings from the history. So we're going to assume when we start this that neurologically that they have no problems. We're going to perform a complete neurologic examination on persons with neurologic concerns as well, things like headaches, weakness, any kind of loss of coordination, or who have shown signs of neurologic dysfunction. And we're going to perform neurologic recheck examinations on persons who have demonstrated neurologic deficits in the past, who have required periodic assessments. For example, hospitalized persons or those that are in extended care. So we're going to integrate the steps of the neurological examination with the examination of particular parts of the body. We're going to record all the neurological data together as a functional unit. So it's all going to be recorded under neurological, basically. We're going to use the following sequence for completing a neurological examination. We're going to look at their mental status. We're going to do the cranial nerves. We're going to look at their motor and sensory systems, and we're going to check their reflexes. Mental status. Are they alert and oriented times 3? Do they know who they are? Do they know where they are? Do they know what time of the day it is? Do they know what day of the week it is? The cranial nerves we'll go over in a minute. We'll go over the motor system and the sensory system. Part of the mental status also includes what? Present, past, and recent memory. It also includes the ability to make accurate judgment and abstract thinking as well, right? And the tests that go along with them. And finally, we're going to check reflexes in an individual when we're doing a neurological assessment. So we want to make sure that we've got things like a pen light, tongue blade, cotton swabs or cotton balls in order to do some of the tests that we need to do, a tuning fork in some cases, and of course a percussion hammer for certain. All right, so let's look at the cranial nerves first. Cranial nerve 1 is the olfactory nerve, which is tasting a sense of smell, right? Persons who report a loss of smell, head trauma, and abnormal mental status persons that actually report having experienced head trauma or abnormal mental status oftentimes will also report a loss of smell. What is this called? Agnosia, right? Agnosia. Normally, a person should be able to identify an odor on each side of their nose, right? And making sure that when we check the olfactory nerve that we do what? We have them close their eyes and we occlude each nostril one at a time when we check to see whether or not they can identify a smell. And prior to that, we're doing what? Making sure that the nares are patent, right? Okay. Give them a familiar substance to be able to smell. Coffee, an orange, vanilla, soap, or even peppermint are common things that we use. Cranial nerve 2, this is the optic nerve. We do this, or we test this cranial nerve through visual acuity, and visual fields by confrontation is another way. Using the ophthalmoscope and examining the ocular fundus to determine the color, size, and shape of the optic disc is another way. So we use the Snellen chart, and we use what? The Rosenbaum. Okay. Near and far vision is what we are checking. Cranial nerve numbers 3, 4, and 6, which are oculomotor, trochlear, and abducens, actually are all tested using the same things. We can check to see for lazy eye, or nystagmus is the other name for that. We can check for ocular motor movement, which would mean that we're doing the H test. We can check Perla, so the pupils are equal, round, reactive to light, and that they accommodate. And we are going to check their peripheral vision, or their visual fields. All of these are going to assess 3, 4, and 6. Number 5, which is our trigeminal. This we assess those muscles by mastication or palpating the temporal mandibular joint in a person that's clenching their teeth. They should feel equally strong on both sides. And if you try to separate the jaws by pushing down on the chin, you shouldn't be able to in a person whose cranial nerve number 5 is intact. You can also check, which that of course would be the motor function, would be palpating the TMJ. The sensory, think about this, the sensory is what they're going to feel, right? Sensory would be with their eyes closed, that you might do light touch by taking a wisp of cotton and putting it on different areas on their face, on their forehead, on their cheeks, and on their chin. So this would be able to check their sensory portion of cranial nerve number 5. Cranial nerve number 7. Cranial nerve number 7 is our facial nerve. The motor function would be that you would note facial symmetry as the person responds to your request to have them to smile, to frown, to lift up their eyebrows, show their teeth, puff out their cheeks. Sensory would be the taste test. Okay. 8 is the cranial nerve vestibulocochlear, or number 8, or it used to be called the acoustic nerve. This we test by testing hearing acuity. You can do this through the Weber or through the Rene, their ability to be able to hear actual normal conversation by doing the whispered voice test, or you can have them do what? The Romberg, which is having them test for balance, right? Good. All right, cranial nerves 9 and 10, which are the glossopharyngeal and the vagus nerves. Motor function would be to, when you're inspecting the mouth, using the tongue blade to have them say ah, and observing that uvula rise and fall, and it should be midline. And having them do the gag reflex as well. This would be the motor portion of this. Sensory would be, for cranial nerve number 9, would be the taste test. But truthfully, it's actually pretty difficult to test that. All right, cranial nerve number 11 is the accessory nerve. We do this by examining the sternomastoid and the trapezius muscles. They should be equal in size. We're going to ask them to rotate their head against resistance that we're applying to their head and to their shoulders. We're going to ask them to shrug their shoulders against resistance, and the movements that they make should be felt equally strong on both sides. the last one. Number 12, the hypoglossal. We're going to inspect their tongue. We're going to make sure there's no kind of wasting or tremors. We're going to have them stick their tongue out. We're going to have them move it from side to side. And we might even ask them to say some words like light, tight, dynamite, and note the lingual speeches. In other words, we want to hear the way that they pronounce the words L, T, D, and N. It should be very clear and very distinct when they do it. Okay, so cerebellar function. We said that in cerebellar function, we are going to be doing several different tests. We do 3 general, we do 1 upper, and we do 1 lower. The three general tests, or the balance test, is really what we're looking at. Would be their gait, which we can have observed when they walked in the room, the Romberg, when we check cranial nerve number 8, and we can have them do several different things, which may include having them do heel to toe, or the drunk walk as I like to call it, walking on their toes, walking on their heels, doing deep knee bends, hopping in place. These are all things that can assess the general balance test. Then we want to look at both their coordination in the upper portion of their body and the lower portion of their body. We may have them do the upper coordination by doing alternating fingers. Remember, starting with their thumb, touching it to their index finger and each subsequent finger, and getting faster and faster. We may have them do pronation and supination. We can have them follow our finger. Everywhere that our finger moves, that their finger will touch our finger. Lower coordination may be in the form of having them do a figure 8 with 1 leg at a time, or you can have them do the heel to shin. Is also another way. Okay. Sensory and discriminatory. Okay. When we are checking cerebellar functions, we are also going to check sensory and discriminatory ability on that individual. We may ask the person to identify various sensory stimuli in order to test the intactness of specifically those peripheral nerve fibers. The person's eyes should always be closed when you are doing this, and you should always make sure to explain to them exactly what you're doing before that you do the test, and you need to make sure that they understand how you are expecting them to respond. Okay. Routine screening procedures include testing light touch and sharp dull. Light touch would be with the wisp of cotton, of course. Sharp dull may be making sure that you're showing this is what dull feels like, this is what sharp feels like, and doing from what? Head to toe. You may do stereognosis, which is the identifying of different objects in each hand. You can do graphesthesia, which is identifying writing of both letters and numbers in hands. You can do both sharp and you can do dull soft touch. These are all sensory and discriminatory. Sensory would be what? The soft touch, the sharp, dull, right? And discriminatory would be like graphesthesia, stereognosis, kinesthesia, right? The next thing that you want to do are deep tendon reflexes, or what we call DTRs. Deep tendon reflexes are measuring the measurement of stretch reflexes that tells us whether or not that the reflex arc is intact at the specific spinal levels, and the normal override on the reflex of higher cortical levels. The limb, in order to be able to do DTRs, must be relaxed, and the muscle has to be partially stretched. You stimulate the reflex by directing short, snappy blow by a reflex hammer onto that muscle's insertion tendon. And then you're going to compare the right and left sides, and the responses should be equal, of course. 1 being decreased, 2 being normal, 3 being increased, 4 being 4 and 5, I believe, or 4 being clonus. There we go. 4 being very brisk, hyperactive with clonus, indicative of disease in some cases. 3 is brisker than average. 2 is average or normal. 1 is diminished, low normal, or occurs with reinforcement. And 0 is no response. Subjective scale requires clinical practice. So you're not just going to know how to do this. This is going to require some practice. Observe spontaneous motor activity for smoothness and symmetry. In other words, we're looking for things like the coordination that they have with being able to suck and being able to swallow. Those are motor functions. Their gross and their fine motor movement. We use this by implementing a Denver 2 test that has requirements of developmental milestones, and it's age specific. And then, of course, we're going to assess muscle tone when we are assessing motor system on infants. When it comes to sensory system, we're going to really perform very little of it when it comes to infants. The newborn actually has hypoesthesia, and this requires a strong stimulus to actually elicit a response, which is why we don't normally do that. Babies respond to pain by crying and a general reflex withdrawal of all limbs. So that's the only thing that they do. By the time that they're 7 to 9 months, they can localize that stimulus and they can show more specific signs of withdrawal. All right. How about in the preschool and school age children? In preschool and school age children, we're going to assess their general behavior while they're playing. That's usually the best indicator. How they react to their parents and whether or not that they're cooperative with both you and the parent. A lot of their motor assessment is actually obtained just from sitting there and watching the child as they undress, as they get dressed, as they manipulate buttons and indicate will a lot of times indicate their muscle strength, the symmetry, whether or not that they're able to do those fine motor movements, the joint range of motion, and fine motor skills. And again, we said that we would use the Denver 2 to screen the gross and fine motor skills that are appropriate for the child's age. We would also make sure that we are noting the child's gait when they're both walking and running. We should remember that in a toddler that they're going to have more of a wide-based gait and the normal knock-kneed walk of a preschooler. Okay, children can balance on one foot for about 5 seconds by the time they're 4 years old, and for about 8 to 10 seconds by the time they're 5, and they can actually hop by the time they turn 4 years old as well. In an older adult, we're going to use the same type of examination as we would with a younger adult. The cranial nerves mediating taste and smell are not usually tested, mostly because they're likely to show some decline in function. Because the decrease in muscle bulk is more apparent in an aging adult's hands, and their dorsal hand muscles are going to often look wasted, but their grip strength usually remains pretty good. So it's just the way that they look, not whether or not that they function. Senile tremors occasionally occur. These benign tremors include an intentional tremor of the hands, head, nodding, and tongue protrusion. Usually when you put your hand on top of theirs, a lot of times it will stop that tremor. Remember that in an older adult that their gait is also going to be slower. It's going to be more deliberate, and it may even deviate from that midline path because of their balance. Documentation, much the same as we've seen throughout all of these chapters. We're going to look at headaches. We want to know about head injuries, dizziness or vertigo. We want to know about seizures or tremors, whether or not that there was any weakness, numbness, or tingling, difficulty swallowing or speaking, whether they've had a past history of stroke, spinal cord injury, meningitis, or alcoholism. Objective, remember that we're looking at their motor and their sensory. We're also looking at their reflexes specifically. Documentation as far as the cranial nerves and the mental status. We want to make sure that their mental status, that their appearance, their behavior, and their speech is appropriate, that they're alert and oriented to person, place, and time. They have recent and remote memory intact. Their cranial nerves we would write out, and we would put what we did in order to test them and whether or not that they were intact. All right, cranial nerves. For example, as far as the abnormals are concerned, what is agnosia? We talked about this. I said it earlier. We want to know about abnormalities in gait. We want to know about abnormals in posture. And we want to know about abnormals in sensory and motor function.